viewers and our esteemed faculty for allowing me to present my work. My topic is dual mobility hip. A patient coming to a clinic, the first question, or they are expecting something from you. The questions will be like, can I squat down? Can I sit on the ground? Can I use an Indian commode? Or can I pray down? So I'm going to present something about dual mobility hip. Instability being one of the most common complications after a hip. Patient present in a routine THR, acetabular, the head size depends on the acetabular size which we are going to use. If it is a 38 to 48 mm of acetabular size, we will use a 22.5 mm of head. 44 to 46, 28, 48 to 50, 32, 52 to 56, 36 size head, femoral head. The dislocation rate depends on the size of the head which we are using. The size 22.5 showing the highest amount of dislocation rate, that is 8.5. Size 28 is 6.49. Size 32 is approximately 5, and size 36 is 0.6 to 1% of the dislocation. An average Indian acetabular size, according to anthropometries done in India, the male acetabulum size is 41.29 plus minus 3.06. In females, it is 37.15 plus minus 0.3. So the most common head size which we use in a total hip replacement being 28. 6.49% was the dislocation in the number of hip in Indian studies with 28 size head, while in abroad it shows a dislocation rate of as high as 9.8%. The most common size being used in Indian condition for hip replacement is 28 mm. Dual mobility hip was introduced by Busquet in 1970. So the concept of mechanism of dual mobility hip, the first articulation, the head engages with the mobile polyethylene liner and follows a typical behavior of a hard on soft bearing of a standard total hip arthroplasty. After that, the second articulation begins to function, which consists of the back of polyethylene liner and the metal acetabular shell. As the P liner articulates, the effective range of motion increases until the impingement of the femoral neck happens with the acetabular shell. In this way, the head liner complex behaves as a larger head, allowing greater degree of movement and an increase in the subsequent jump distance for dislocation. In a dual mobility hip cup with a 22 mm and a 28 mm femoral head demonstrate significant greater range of motion as compared to a conventional THR with a similar design. As the head size increases, the range of motion as well as impingement of the neck against the PE liner reduces and increases, it reduces the risk of intraprosthetic dislocation. The mean dislocation rate for a primary dual mobility is 0.9%, while in revision cases it is 3%. The mean rate of intraprosthetic dislocation was 0.7% in primary and 1% in the revision total hip cases. This is a diagram showing, can I get a pointer? Yeah. Yeah. So this is a diagram which shows, okay, I'll show it on the. So this is a diagram which shows the mechanism of movement of a dual mobility hip. The inner polyethylene, the inner metal cup or a ceramic cup moves inside the polyethylene liner first. The neck impinges against the polyethylene liner here, and further increase in the range of motion happens once the polyethylene liner moves inside the acetabular shell, giving an increasing in the range of motion. A size 28 cup, the jump distance is small, while a size 36 head, the jump distance is a bit more, less than the 36 mm head. So this gives us more stability for preventing dislocation of the hip. So I'll just present some patients of mine. 87 years old patient, operated 15 years back. Just with a twist of her leg, while getting down, she dislocated her hip. She was completely mobile, walking before the dislocation. I have done a cemented acetabular, just changed the acetabular shell into a dual mobility shell, retained the same stem, which was done by the prior surgeon. This is a 27-year-old male, high demand male, sports person, plays cricket. He had bilateral avascular necrosis, did a primary dual mobility hip on both sides in single setting. Today this is the function, this is the range of motion which he has achieved. Clean out. Sauda. Next. He's an obese patient, again bilateral avian hip, ficatardate classification, grade 3, done a bilateral dual mobility hip. Because he's slightly obese, it is difficult for him to get up. Otherwise, he's achieved full range of motion. Next. Unilateral dual mobility hip done in a 36 years old guy. Next. 76 years old patient with a fracture neck femur. I have done with hybrid system, hybrid fixation, uncemented on the acetabulum and cemented in the femoral stem, achieved full range of motion, able to sit down and walk, squat down. I have presented my work in American Association of Hip and Knee Surgeons. I have presented my work for young avian patients, uncemented dual mobility hip in young patients.